Welcome back to another episode of Startup Health Now, in which we get to know the entrepreneurs and the innovators who are transforming health as we know it. I'm your host, Logan Plaster. Before we get into today's episode, I want to speak directly to any founders and CEOs of health innovation companies that might be listening. Startup Health has just launched a new annual membership program that opens up broader access to our coaching, community, and media. What is so cool about this program is that we put members of our network into mission-aligned groups we call health moonshot communities, so that you're collaborating with folks who are equally passionate about women's health, children's health, metabolic conditions, whatever your focus is. We've done this successfully in type 1 diabetes and Alzheimer's disease, and now we're scaling the model across 14 health moonshots. We've supported more than 500 startups since our founding, and we've discovered that this step of organizing founders around specific health goals is the great unlock. So come check it out and apply to join our next founder info session at startuphealth.com/membership. Now, on to today's show. Today's guest is a special one for a number of reasons. For one, Dr. Toby Cosgrove was the CEO of Cleveland Clinic for 13 years, during which the $8 billion organization was ranked as the #2 hospital in America. Few people have a better macro understanding of the American hospital system and healthcare delivery writ large than Dr. Cosgrove. We're also always happy to have Dr. Cosgrove on the show because he's a vital voice on Startup Health's own board of directors and understands our mission and vision intimately. This wide-ranging episode is pulled from a recent masterclass we held in front of a live audience of members of the Startup Health community. You'll get to hear Dr. Cosgrove cover everything from hospital economics to hard-won lessons in executive leadership. He even opens up about the legacy he hopes he left at Cleveland Clinic.
I think probably the only good thing that I did that was transformational for the organization is I asked the question, why are we here?
In addition to hearing Dr. Cosgrove's wisdom, you'll hear some tactical questions from founders on the call. Let's get into it. Toby, thanks for joining us.
Logan, thanks for having me.
I would like to start by understanding a bit more about your time at the Cleveland Clinic as a way to kind of pull back the curtain on what it's like to be an administrator at that level, a hospital leader at that level. So you went from being a practicing surgeon to being in that C-suite. And I'm sure you thought you were a surgeon, you thought you knew what you were getting into. And then the realities kick in. So tell us about some of the surprises of life as a CEO of the Cleveland Clinic as a way to also sort of debunk some of the misunderstandings that founders on this call might have.
Well, Logan, everything changed. I used to wear scrubs, read the New England Journal of Medicine. I hung out in the operating room. All of a sudden, I'm hanging out in the boardroom, reading the Harvard Business Review, and I had to go out and buy suits. But the biggest shock of all was I instantly became a public figure. And not only was I responsible for the people who worked within the institution, but I had responsibility for the communities that we serve, which changed my life enormously. And I had a huge change in responsibility that went far beyond the walls of the institution. And so when I spoke for the institution, I spoke for the community, and there was a very major change in my life that I hadn't dreamed of, planned on, or expected.
What misunderstandings or misconceptions do you think that founders or CEOs, even those on this call, could have about hospital leadership? Misunderstandings that could even cause them to have a go-to-market strategy that's not going to be successful?
Well, first of all, I have to say that I had no preparation for being CEO at all. And I honestly can tell you, I didn't know those parentheses on P&Ls were bad things. And that's how naive I was at the time that I got the job. So I went through a tremendous learning curve. And I had to dig in to learn things that I had absolutely no idea about. But the interesting part about it was that I think that what I learned was probably the best thing you can do is be curious, and curious about all kinds of things. things about that I was never aware of: architecture, art, um, business, different specialties, government, all of those I had to learn about and try and educate myself about. Generally not very good at most of them, but certainly fascinating.
Yeah. What are you most proud of about those 13 years as CEO?
I think probably the only good thing that I did that was transformational for the organization is I asked the question, why are we here? Um, why do we have a hospital? Why do I get paid? Why do we all have jobs? And after thinking about it in preparation, I realized it was for patients. The reason we educate, the reason we research, the reason we do clinical care as for patients. And as a result of that, I made that our sort of our mantra: patients first. And every fork in the road or decision that we made was we asked the question, what's the right thing to do for the patient? And, the more that I have talked to leaders and thought about leadership, and I've had some interesting opportunities to do that with presidential historians, et cetera. Um, they say that what makes the real essential thing for a leader is a virtuous vision for the future. And then the second thing is you have to figure out how you implement that, whether it's through emotional intelligence or for of your own, or for the ability to hire people that can execute on your vision. But you have to have a vision about where you want to go. Otherwise, you're never going to get to where you want to go.
Do you feel like that vision and purpose has stayed intact since you stepped down as CEO?
Yeah, I think it has. I think that surprisingly, it took me, well, not surprisingly, it took me about 5 years before I thought it would stick. And then I think it became part of the culture, and we did a lot of things to try and make it part of the culture. And I got awfully tired of saying the same things over and over again, painting it on the walls,
Yeah.
closing every speech that I gave with an example of why we were here. And I think that it did ultimately resonate with the population, and I think the culture has been maintained.
You just gave three examples, painting it on the wall, using examples in everything you spoke. For founders on this call who want to instill what did you say, a virtuous vision for the future in their companies, what are some other practical ways that they can hammer that home, and hopefully not take 5 years if you have got a short runway?
Yeah, I think you have to verbalize it. I think you have to demonstrate it in every way that you possibly can, whether it was painting it on the walls or figuring out what demonstrated it, and you have to walk the walk.
Mm.
It's amazing to me, and this is probably not as poorly understood by most people. Everybody knows everything that you do as a leader. They'll know when you're on vacation. They know where your favorite restaurant is. They know where you spend your time. They know what time you get in. They'll see if you think it's important to shine your shoes, wear a tie, how you dress, how you respond. You can't leave the office with a frown on your face, or they'll think the sky is falling. Um, so they watch everything you do, and you set the culture of the place. And the power of leadership, I don't think, can be underestimated or overestimated. It is incredibly powerful. And I recently finished a book on Steve Jobs and another one on Elon Musk. And all you have to do is read a little bit of those, and you'll see the incredible power of those. And if you look at the president of the United States and how they affect the culture of the place, you realize that it is enormously powerful job and once you get into leadership.
Yeah. You talked about your job and your impact being primarily purpose, 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 really that vision, that vision, that vision. And yet, obviously, there's a huge economic side to running a hospital,
Mhm.
and the economic drivers really push a lot of decision making. And so let's get into some of the challenges and opportunities within hospitals today. Health transformers in startup health, they're all about solving pain points. And yet with a hospital, sometimes those pain points feel like they're in a black box where it's the pain point behind the pain point. It's the financial driver for the buyer who you don't get to meet. It's not the problem that you see on the floor in the unit. So let's talk about some of the key drivers and pain points and challenges within hospitals today. And we'll break it into some different parts. And maybe we'll talk about the money side first, the current economic state of hospitals, so that founders can sort of understand, okay, if I'm selling into these groups, these are some of the macro conditions I should be keeping in mind.
Yeah. So let me talk about the finances and then a couple other ones just to give us an outline of where I see the major problems. Right now, hospitals are running an average of a 2% margin across the United States. About half the hospitals in the United States are running in the red. And that has been for several reasons. One, it has been inflation, which has increased the cost of pharmaceuticals by about 13% of the cost of people, and salaries about 12%. And at the same time, Medicare and other payers have not kept up with that. And so hospitals are under enormous financial distress at the moment, which affects trying to sell into these organizations. It has lengthened the sales cycle substantially. I guess the other thing is that there is a huge workforce shortage, about 2 million unfilled jobs in the United States, of which say 500,000 of those are nurse shortages, and there's something like 50,000 primary care physician shortage, which translates into 83 million people in the United States don't have a primary care physicians. And the third thing that is an important factor is the explosion in knowledge. There are now 30,000 journals putting out 1.8 million articles, scientific articles a year, which means that the total amount of knowledge in healthcare is doubling every 73 days. Nobody can possibly keep up with that. And so we're going to have to find a way to do that. Rather than prattle on too far, those are the main
Yeah.
things that I see as
Let's talk, let's
involving the healthcare providers.
Let's talk about the workforce shortage. We've got a number of companies that have seen that challenge as an opportunity to innovate. Where do you think we should be concentrating our time and our resources? Sort of how far up the chain should we be looking to address this problem? What kind of advice are you giving to hospitals?
Yeah, so I frankly think that one of the great opportunities we have right now is with AI, and this coming in and beginning to manage the repetitive tasks that are going on in healthcare. And just to give you an example of the repetitive task, Cleveland Clinic has 3,500 people that work in revenue cycle, 1,000 people in call centers. And those things ought to be able to be automated. And then there is technology that is going to reduce the work of the clinicians. I see right now the ambient listening devices that are coming along for physician recording, and so they don't have to spend all their time uh, tapping on the computer while they're talking to the patient. I see technologies that will automate vital signs, taking vital signs, reducing nurse work. So I think the first place that you're going to see AI step in is going to be in the administrative side. And the reason for that is it's very low risk. And it should be able to reduce the cost and improve the efficiency there enormously.
What about our gap in primary care physicians? Obviously, there's some bigger issues there.
Yeah, the primary care physicians, I think you're going to have them become more efficient. And frankly, there's going to be a lot of the things that they do on a regular basis that can be automated. For example, I saw recently a nurse agent which can answer questions like, I've got a colonoscopy tomorrow. Is it okay for me to eat apples? And so there's that would reduce a lot of the work that goes into that workforce and answer a lot of questions that physicians frequently have to answer. That will help them a lot. Plus, so they'll be able to look at bigger panels of patients. Generally, the panel of a primary care physician is a couple of thousand. It could be double that, and which would help take care of a lot more patients with primary care physicians. Plus the fact that it's going to democratize knowledge. Think, for example, the other day I had an opportunity when I went to AI to OpenAI to see version 5.0 of chat. Boy, it can answer a lot of questions. So there's going to be a lot of knowledge that's going to be quickly available to patients that will take a lot of the work away from physicians.
We're going to get into questions in the chat in just a minute, but one more question to follow up on. You talked about hospitals having razor thin margins, 2%, half of hospitals operating in the red. How should founders be thinking? Let's say a founder's got an amazing innovation. It's best thing since sliced bread. They're going to a hospital and they're dealing with a hospital that's operating in the red. How should that change their thinking and their approach?
Okay, so I think it depends on who you're talking to in the hospital and what your pitch is. If you're talking to the members of the executive team, their primary concern is going to be how they become more efficient and reduce costs. If you're talking to clinicians, then you want to talk about how you improve the quality of care and their workforce and their workload. So it's a very different pitch depending upon who in the system you're talking to. No sense in talking to the CEO of the hospital if it's going to cost more and yet give a marginal improvement in quality.
Yeah. All right, let's get into some questions from the chat. We've got a bunch of good ones. Let's start with Aaron Atlas from DreamMed.
Thank you very much. And hi, Toby. So I'm very much connected to all the things that you said. DreamMed is basically automating the way physicians are analyzing data for people with diabetes. We have a technology FDA cleared that is helping physicians analyze the data that's coming from the devices and provide recommendations on how to optimize insulin delivery, primarily because most of these patients are now going to be hit primary care. Shortage of endocrinologists, as you're well aware, would like to empower primary care to do this job as much as possible. So that's what we're doing right now. We're at Yale. We're selling at Yale, a billing clinic in Boston Children. And I think the main question is for you is very much connected to what you just said. What is the pitch? Because, each stakeholder in a health system has a different interest. The executive team has one interest, the IT team has a different interest, and the clinician has a different interest. But you will not be able to make a sale if you're not get any endorsement from all the three of them. So the main question is, who should be the first point to enter? Should we bring in the clinician? Should we bring in first the IT if we're selling the software? Or should we approach first an executive? Who should be the first point of entry when we're talking to a health system? Or it doesn't matter. You need to bring one and let him help you bring the others and make sure that you align your pitch according to the audience.
Okay. First of all, let me go back to what I said earlier about CEOs. Um, if you can get to the CEO, that's that he will be a great driver for any new technology. And as I said, so the AI, particularly, let's talk about the AI revolution. That is going to be top-down driven. That's not going to bubble up from the bottom. And so if you can get to the CEO, try to get to the CEO. If you can't get to the CEO, then the second best, and I think you want to do it simultaneously, is going to be a clinician champion that will help drive it. And actually, you're probably going to need both, but the more effective one is always going to be the CEO if you can get to them.
Yeah, it's pretty hard to get a CEO of a health system.
I know.
What I'm hearing you say, Dr. Cosgrove, is that the physician champion is going to bring in that sort of patient-centered, that purpose-driven side of it.
Yes.
And that's going to have a lot of weight for the team.
Yes.
Okay, great question, Aaron. Let's go to Michael Harris from Niche. Michael, you can come off mute.
Thank Dr. Cosgrove. It's great talk. It's somewhat music to my ears, but also disheartening in many ways. My name is Michael Harris. I'm the co-founder and director of Niche, Novel Interventions in Children's Healthcare. We target young people with mostly with diabetes, but also with other complex and chronic health conditions who experience significant social challenges that drive a lot of our healthcare expenditures in our institutions and on our payer side. We partner with Medicaid to pay for the service. Like in my question, I love the why are we here question. I think my experience in working with C-suite folks and other people in leadership in healthcare institutions and on the payer side are so far away from why are we here and why are they here. I'm curious to hear from you as to what the best strategy is to bring them back to that question, because I think that's a really compelling question.
Well, payers, I think they fall in a couple of categories, the government payers and the private payers. And clearly the private payers are trying to figure out how they can keep their 15% margins. And the public payers have more of a public responsibility, but nonetheless are trying to balance a budget from a financial standpoint. So I always think that if you possibly can, you make the case, a financial case, how you're going to wind up ultimately saving money. And clearly the community benefits rings louder for the public payers, the Medicaid and the Medicare payers, than it does for the private payers.
Maybe I'll add a follow-up here. Just you talked, Dr. Cosgrove, about hammering that vision, that purpose, and really taking years to inspire. And I'm just thinking, like, if you feel if a founder feel like Michael with Niche feels like a major driver for their product needs to be the community impact, what are some ways they can be more effective? Like, how can they convert the person they're talking to?
Well, I think, first of all, I'm a big believer in radical transparency. And the transparency for healthcare systems they are a community asset, and they have to be, I think they need to respond by being candid about their outcomes, regardless of where they are. And I think that healthcare delivery systems have to be candid about the quality of care that they are producing man by man. You can't imagine how popular I was when I started to insist that everybody's HCAP score be put out in the institution by name and rank order. And similarly, I think you need to have your quality metrics put out to the community. And I think if you begin to talk to the community and the community at large about what you're doing over time, that message gets through. But there's a lot of ways to do it. I mean, you've got to talk to the media, you have to talk to the politicians, a lot of constituents to be brought into the discussion.
That's good advice. Hey, thanks for the question, Michael. Let's go to Christy Sheehy from Sea Light. Christy.
I'm Christy. I'm the CEO and co-founder of Sea Light Technologies. We've created a novel retinal eye tracking device, and we use the motion of the eye as a biomarker for brain health. And so one of the big questions I have, we have our physical device now as an FDA-cleared eye tracker, and we're going to be adding AI for disease detection using certain ocular signatures for neurodisease. One of the big bottlenecks we face is insurance coverage. And so I was curious, with your time at Cleveland Clinic, for the technologies that you saw that were successfully integrated into the workflow and into the clinic itself, in general, how did they go about their insurance coverage? Did they come in with new codes, existing codes, category 3, no code at all? I mean, how have you seen the most successful integration into the clinic?
Yeah, well, I think you got two things that you can do there. First of all, generally you're going to have to, for the finances, you're going to have to get a new code. But secondly, you stop and think about the work reduction that can do for neurologists, if you will. That's a substantial tool. And I would think that neurologists would be interested in bringing that in and be your champions and getting that into the institution. So I would lean heavily on those guys and gals to help you bring it in, and ultimately they'll want to drive the code that goes with it. But I think it's a work reduction aspect that you can stop and imagine. I would assume that you ought to be able to do it virtually.
So really the physician champion, again, kind of coming into the picture.
Yeah,
okay.
Totally.
All right, Christy, thanks for the question. Let's go to David Sarabia from In Recovery.
Hey, Toby, nice to meet you. Anyway, my name is David Sarabia. I am the founder of In Recovery. We are focused on addiction recovery. We basically are helping digitize that whole process of helping people get better. My question was that since I'm not a medical doctor or a scientist or like many of my peers in the space, it's my first time in healthcare. I've always prioritized having clinical representation at the C-suite. I often get a lot of pushback for that because obviously it's not practical, and many, especially as a startup, both from investors and some of my board members. But for the most part, I guess my question was really, how did being a physician, a surgeon, affect your decision-making process as a leader at the Cleveland Clinic?
There's an interesting study that's been done, which has really been verified multiple times, and that is looking at hospitals that have physician leadership versus those who do not. And the quality metrics are higher in hospitals with physician leadership. So as my predecessor frequently said, that it's a lot easier to teach a doctor business than it is a businessman medicine. And so I think that I am a big believer in physician leadership. But I think that in order to have it effective, you have to team well with business people. I think that the huge success of the Mayo Clinic from the very get-go was that they had a very close partnership between the Mayo brothers and their business colleagues that really set up the basis for the Mayo Clinic's success. And I think that you really can't do one well without the other. I think ideal teaming is really essential, because God knows I would have been lost without the business acumen that surrounded me.
Thanks for the question, David. Let's go to a question from Alexandra Greenhill from Care Team. Alexandra.
My question was more, you mentioned physician leaders. We have tons of physician champions. I'm a physician myself. With Care Team, we essentially have created a tool to allow a clinical team to manage their complex patients along a pathway, not episodic and reactive, but more proactive and predictive, across systems in collaboration with family and others. And so we have champions who get it, but they now need to sell it to an administration that's used to doing things as usual, and they seem to stall. And not everyone is savvy, not every disease is sexy. And so how do we, have you seen any good examples of where and how this can work, even if the population of patients is not the three biggest priorities of the hospital for that year?
Okay, so I've worried a lot about physician leadership, to be honest with you. And I think let's look at how you get to be a physician. You got to go to medical school because you got through organic chemistry, and then you went to medical school and you wound up memorizing for 4 years. And then you started probably a 5-year residency, which all you did is do what you're told, and you emerged in your mid-30s from that, having not been asked to have an original thought or do anything differently other than you were taught. So I think we were selected and trained to be technicians, not to be leaders or original thinkers. And as a result of that, and then on top of that, physicians get selected in many cases to be leaders because they're great technicians. Just because you did a great colonoscopy doesn't mean you're a great leader of people. So I think that there's been very little selection or training about leadership in healthcare. I started out worried about that, having made some terrible mistakes in who I appointed on the strength of their CV, and found that they didn't have any capabilities of leading people. And so I began to think about, okay, how do you train leaders in healthcare? And so I thought about, okay, where have been the great leadership forums that have led people to learn to be leaders? And they used to be GE, or you went to one of the big banks, or you went to Procter and Gamble. But then the more I thought about it, I thought the people who've really been at this business of training leaders the longest have been the military. And they've got a very simple system that do it. You get a small group to lead, and if you do well at that, you get a bigger group. And if you do well at that, you get a bigger group. And in the meantime, you get the academics in between those. They send you to Harvard Business School or the Naval War College, so you get the academics that go with it. And by the time those guys emerge with stars on their shoulders, they're very impressive leaders. As a result of that, we started figuring out how we would begin to train leaders at the Cleveland Clinic. And we took doctors. We eventually got 250 doctors in some sort of leadership position. Initially, we sent them off to business school and promoted them as they were successful. Some were successful and some weren't. Some went on to be hospital presidents, and some did well, some didn't. But just to give you an example, my successor decided he wanted to have more academic. He was a heart surgeon, wanted to have more administrative training. He got an executive MBA at Harvard. We sent him to Abu Dhabi for his chief of staff. And then he became president of the hospital in Abu Dhabi. And then he became my successor. So we worked hard at this. And now internally, we have a leadership training academy at the institution. And it has gone from being just doctors to leadership at all levels. So I think you have to think about the different talents that go on into becoming healthcare leaders.
I appreciate that, Dr. Greenhill. I can tell she hit on an area of particular passion for you, Dr. Cosgrove. Your detail. I just appreciate your thoughtfulness in the maturing of a career. There are so few places in really our market, really at all, where leaders are thinking about taking a taking an employee through the education they need, through the training they need to come out the other end better, like you said with the military, which is a great segue to our next question from Avonlea Christine.
Hi, it's nice to meet you. I started a company based on a need that I saw with my mom and my grandma while I was in New York City and they were in Montana, which is we have 54 million unpaid caregivers and a very massive aging population. And I just wanted to build a solution to leverage them into the healthcare system to reduce burden for my mom, but also to give plans a way to really communicate with members and keep people healthy at home. So that's what Avonlea Care is. But I just really wanted to thank you, one, for your service, and two, what did your story? I read the story about you volunteering in a civilian clinic and just being in Vietnam. How did that impact you as a leader in your career?
Vietnam was very good for me. It was probably the first time that I had an opportunity to have a leadership position. I was in charge of a 100-bed casualty staging flight where we evacuated all the casualties from the northern half of Vietnam, about 22,000 during the time that I was in charge. And a couple of things that I learned. First of all, we had 2 doctors, about 15 or 20 nurses, and a squadron of corps people. And I realized that you could take an awful lot of the healthcare activities and train people to do it as technicians that didn't require an MD or an RN to go with them. The second thing I learned was the military had a system of evacuation of casualties. So you got hit, and then you went to a tent hospital and got the bleeding stopped, and your wounds splinted, and then you got moved to the Saigon or Da Nang, and where they had the specialist doctors. And then when you're well enough, you got evacuated back to a series of hospitals along the way. And what I realized is not all hospitals can be all things to all people. We now have a transportation system in the United States, be it on the ground or in the air, that moves patients. And as a result, we started a transportation system at the Cleveland Clinic. We move about 30,000 patients a year in and out of hospitals. And we do it by air, by ambulance, by anything, some come in. And so not all hospitals have cardiac surgery or neurosurgery. But you can move patients to places that do and do it well. So I learned that from my experience in the military, and I also learned war sucks, and there's no good guys in war. Nobody wears a white hat.
Yeah. I hope they make a movie about your life one day. That'd be cool.
I hope not.
Appreciate the comment and the question, Avonlea. Dr. Cosgrove, let's shift gears a little bit. We've got all these folks on the call and so many hundreds and hundreds of healthcare startups who would love to sell their product into an organization like Cleveland Clinic. And so I want to hear what kind of innovations, in trying to get a little bit more granular, a little bit more specific, would you actually like to get pitched? What are you actually hoping gets solved by an innovative startup? Obviously, we've talked about AI in general. We've talked about improving the knowledge translation time cycle. But are there specific tools and services that you just wish would get presented and that would be a welcome addition?
Yeah, so I look at everything can be improved. There's not one thing that we do now that you can't get better at. And I think that's the obligation of an organization, to be constantly dissatisfied. And I think you have to, you cannot be complacent about anything that you do. There's always an opportunity to make it better. And, I used to think about everything that I did in the operating room, how I could make it better, how I could make the incision smaller, how could I make it faster, how could I take better care of the heart when it was stopped, all those sort of things. And it changed the whole practice. And the other thing that really worries me about healthcare, and I think this is one of the opportunities that you all have that has not generally been around, that is run by AI, is the time that it takes from a proven technology to become standard of care is 13 years. That's the half-life of a doctor. And so essentially, what's that telling me is you don't learn it in medical school or you don't learn it in your residency, you're not going to practice it. Now, so hopefully now that information is universally available, that's going to begin to shorten that time. And if it doesn't, it has to shorten that time, or we're not delivering the best care that we can. So I just see this as an opportunity to, if you will, democratize knowledge, and ultimately to help make decisions at a level that you don't have to be 10 years in residency in order to have those answers, and it's going to empower primary care physicians to look after more things than they have in the past.
I love your comment about making every little aspect a little bit better. And I'm sure every founder on this call thinks they have a product that can do just that. And they've all got a pitch deck to prove it. Everyone's presenting their product. The team is the best. They save money. They've got a vision. When you're thinking about a presentation of a product or a company, what are some of the aspects that could kind of tip the balance for you? Is it more about the team? Is it more about the vision? Is it more about the technology they use? Obviously, it's a mashup of everything, but are there aspects that kind of tip the scales for you?
Well, the thing that's tipping the scales right now, I hate to tell you, is financial. That's the hard part of it.
So dig into that. Let's get specific.
How are you going to save money? How are you going to reduce the number of people? How are you going to make people more efficient? How are you going to wind up when you got value-based care? How are you going to keep people from coming to the hospital? That is the pressure that healthcare delivery systems are on right now. And so it's a mean reality, but it's true.
Yeah.
I'm working with a hospital now that is losing $10 million a week. Now, you think that they're going to say, if you come to them and say, well, I got a great new thing for you that's going to increase it, they're worried.
Yeah.
Like they're out of business.
What's your advice for a company that knows they can save an institution money? How can you be most effective in making that argument so that you can shorten the sales cycle and really go to market?
Yeah, so there's a couple of things that I've seen people do. First of all, a lot of hospitals are now pitching, saying, we'll bring it in, but we want a piece of the equity. And I think that's a good thing, because if you give them a piece of equity in your company, then they have a reason to try and push it along. And so that has been quite successful in getting some people through the door and onto the clinical route, which is sort of a surprising way to do it, but it's actually, I know many hospitals are asking for that now.
Yeah. Matt Martin from Precision Health Reports has a follow-up to that. So go ahead, Matt. You can come off mute.
Hey, thanks, Logan. Dr. Cosgrove, appreciate your time here. So a quick question, kind of a follow-up exactly what you just said there about cost savings and reducing cost. So Precision Health Reports, we deliver a cardiometabolic risk assessment that harmonizes all the various guidelines that are built to reduce incidences of metabolic syndrome, type 2 diabetes, and cardiovascular disease, and provide a personalized approach to that. So rather than just having lab values that are just numbers on a paper, we come back with a guideline-based personalized report that shows where someone is on the risk continuum and what their threshold goals should be to reduce those instances of disease. With that, what we offer is a little more expensive than just labs alone. We are not currently covered by any insurance, so our primary targets currently are direct primary care physicians and those direct primary care systems. With that, is the focus on cost savings a much higher priority than bringing in a higher quality product that does reduce diseases?
Yes. Sorry. Yes.
They'll understand.
Is that the answer you were looking for?
It wasn't.
No.
It was the answer I expected, just not the answer I wanted.
No, I know. That's the reality of what we're talking about. But I mean, you can ultimately figure out, if you talk with a value-based care system, how you can come back to them and say, look, over the long term, we're going to save you money. But you have to also figure out that a lot of the insurance-based value-based care are very short-term.
Right.
And, you can't give them the 10-year result. They're not going to be enthusiastic about that, because they're not going to have that 55-year-old anymore. 10 years from now, they're going to be saving money for Medicare, not for you, not for them.
Ken from Synaptica, go ahead.
Yeah, Dr. Cosgrove, thanks so much for this. Synaptica developed personalized brain stimulation for Alzheimer's. We have phase 2 data that is unprecedented, published and peer-reviewed. I've heard this story about risk sharing for 10 years. Going back 10 years, it was going to change the landscape of medicine. We're going to do these risk sharing arrangements. It never happened. So risk sharing, cost sharing, do you see these elements as still likely in the future? And or do you like the model of doing a pilot where it's like, don't believe our financial model, let's do a pilot at one of your sites, let's put our device to work and show you that the total cost savings are there?
Yeah, I think the most common thing that I'm seeing is people want to have some sort of trial. And frequently they'll say, well, we'd like to do a trial, but we don't want to pay for it. That's the tough part. And that's where the equity begins to get past that in many cases. So you can do a trial and frankly, giving them equity doesn't really cost you very much.
Got it. Thanks so much. Great answer.
Appreciate the question, Ken. I think we could squeeze in one more, either comment or question from Stephen Krein.
Hi, Toby. It's great to see you, and I'm so excited that so many of our health transformers got to see what you and I and the board get to see every quarter during our board meetings, which is your incredible wisdom and insights into the way the world is working in healthcare today. You gave me some really great advice about a year and a half ago as we were navigating, I think, the new world, the way the market was working, and you talked about this philosophy of people just want to be led. And I thought for those CEOs and co-founders who are leading companies today, it was really good advice during tough times. And I've appreciated and come back to it a lot. But if you could elaborate on that a little bit from your perspective on how important it is for all of us, no matter what we're going through, to remember that.
Yeah, I don't think there's any question about that people do want to be led. But I think they want to be led by a greater vision of what could be. And that's why I go back to the idea of having a vision for where you're taking them. It has to be a virtuous vision of where you want to take people. And if you, and they want to do, everybody wants to do something that is contributing to the greater good. And they may bitch and moan about the incidentals of it, about how you're doing it. And I wound up having at least 5,000 people who could have done the job better than I did at the Cleveland Clinic and told me so every day. But nonetheless, I think if you give them the vision, then nobody really complained that they were, when you said it's about the patient. No one could really contest that, because that's why we were there. And it didn't make any difference if you were a teacher or a researcher. That's what we're all in doing. And so if you give them a great vision, and people want to be brought along and be part of that vision, and you see it time and time again with great leaders just do that.
Yeah, well, I posted to the chat, and we'll repost it again, the video that you did on empathy, a remarkable 4-minute video telling your vision to all of the stakeholders and people in the universe of Cleveland Clinic. And if anybody hasn't watched that, watch it again. We'll repost it again. But Toby, thank you as always for all of your time and support and encouragement to this community that really is working tirelessly to overcome all the challenges you outlined today.
Well, I didn't do the empathy video, the team did it, but they did a spectacular job. And if you don't cry when you see it, you don't have a heart.
Well, that's a great note to end on. Dr. Cosgrove, it's clear from the questions, the appreciation of this community for your time. And I thank you for your wisdom and your candid answers to everybody. So appreciate you spending an hour with us today.
You're doing great work. Keep it up.
Thanks for listening to Startup Health Now. We'll be back again with another episode next week.